Our next speaker, Dr. Fred Appelbaum, is the Executive Vice President and Deputy Director of the Fred Hutchinson Cancer Research Center. He is head of the Hematopoietic Malignancies Program in the Fred Hutch University of Washington Cancer Consortium and principal investigator on several National Institutes of Health grants. He is the author of over 900 scientific articles and was the lead author on the first paper to describe the successful use of autologous marrow transplantation. Dr. Appelbaum's current areas of research center on the biology and treatment of hematopoietic malignancies, particularly acute myeloid leukemia. Dr. Appelbaum is going to talk to us about the 25 years of progress in the art of hematopoietic cell transplantation. Please join me in welcoming Dr. Appelbaum.
Thank you. Shortly after the atomic bomb blasts in Hiroshima and Nagasaki, thousands of people were killed by the heat and the blast effect. And then within a couple weeks, others started showing up at the makeshift first aid tents around the blast sites with bleeding and infection, what we now know to be radiation toxicity. But that wasn't really understood at the time, and so shortly after the end of the war, they developed an Armed Forces Radiation Research Institute in Chicago to try and understand more about what was happening. And there was a guy at that institute by the name of Leon Jacobson who performed an experiment which was very telling. What he did is he took mice and radiated them, but then took the spleen, exteriorized it, and put it into a lead box, still connected to the mouse, but now the spleen was not being irradiated while the rest of the mouse was. When he radiated a mouse that did not have the spleen shielded, the mouse died with marrow failure. No white cells, no red cells, no platelets, just like what happened to the victims of the atomic bomb blast. But when he took the spleen and shielded it in lead, the animals survived. Now, what had happened and what was subsequently shown is that there were hematopoietic stem cells, the stuff that's in the bone marrow, that were protected and were able to reconstitute the entire hematopoietic system of the mouse after the radiation was completed. Now, the implications of that were not lost on a young Don Thomas, who was just finishing up his hematology fellowship at the Brigham. And Don had the insight that if you could destroy a normal bone marrow with radiation and then give it back, couldn't you destroy an abnormal bone marrow with radiation and give bone marrow back from a normal person and perhaps cure every disease of the hematopoietic system? That includes diseases where the hematopoietic system just fails, like aplastic anemia, or where you're born with an abnormal hematopoietic system, like in sickle cell anemia, or where the hematopoietic system becomes malignant, like in leukemia or lymphoma. And so Don left his residency and moved to Cooperstown in upstate New York and started working on this problem. And over a number of years, one by one, he started to overcome some of these issues. And so, beginning in 1949, we have that spleen shielding experiment. And then in 1957, Don, while working in Cooperstown, performed a transplant for a young kid who had acute leukemia who happened to have an identical twin. He radiated this young woman, took bone marrow from the identical twin, infused it intravenously, and the patient recovered. Now, when he tried to do this in individuals who didn't have identical twins, the results were uniformly disastrous in the next 6 patients. And so Don said, whoa, we have to understand a lot more, because people didn't understand anything about HLA or matching at the time. And so Don went back into the laboratory, first working in Cooperstown and then moving to Seattle in the late 1950s, and started working in an outbred animal model, the dog, and showed finally in the early 1960s that he could get successful allogeneic transplants between littermates, by figuring out which dog matched the other, radiating the animals, giving bone marrow, and understanding that you had to give post-transplant immune suppression to keep this new bone marrow from reacting too vigorously against its host. And so with those three insights, how to match, how to give the right amount of preparative regimen, and how to give post-transplant immune suppression, Don had now successful transplants in dogs. And then, a few years later, started going back into the human setting, and in the late 1960s, just about 50 years ago, the first successful transplants for leukemia were being reported by Don and colleagues. As mentioned, I was lucky enough to be involved in the first application of autologous transplantation, and by 1990, Don had won the Nobel Prize for his insights. Now, Don was an incredibly bright man. He was incredibly driven, and he had a lot of scientific insights, but he also understood that in order to get this done, it took a whole team of people. It took other doctors who were specialists in infectious disease and GI disease. It took a great group of nurses. It took support staff. It took administrators. And Don really did show that it was a team effort. And to exemplify that, if you get the call from Stockholm and you live in Seattle, it comes early in the morning, around 3 or 4 in the morning. And after Don got that call, he came to work as he always did, and the first place he went to was the nurses' station at the transplant center to thank the people that he said were the most important in getting the work done. So that was in 1990. Now, Don retired shortly after that, but the story of transplantation did not stop there. And what I'd like to do is talk about the next 25 years. What's happened since Don got the Nobel Prize, and transplantation had gone from being an idea to being something that was now sort of a mature technology. But as I'll show you, there has been a lot that has happened in the last 25 years, and one of the biggest issues that I'd like to bring up is what Gary said, that it was really, what we'll do is we'll draw a straight line arc from transplantation to today's adoptive immunotherapy using CAR Ts and TCRs. And so we will talk about the indications for transplantation, what's changed about the tolerability of transplantation, the availability of transplantation, making it more accessible to large populations of individuals, and then we will talk about capturing the graft versus malignancy effect, which I think has culminated in today's TCR and CAR T-cell therapies. So turning first to the indications for marrow transplantation. Generally, we do two kinds of transplants. We do autologous transplants, where one uses one's own stem cells, and then we do allogeneic transplants, where one is using donor stem cells. In the setting of autologous transplantation, there have been a series of prospective randomized trials which have established the indications for autologous transplantation. Starting first in non-Hodgkin's lymphoma, and these are some of the iconic studies that have been done. This was a study that took patients who had non-Hodgkin's lymphoma, who had failed first-line chemotherapy, and then were randomized to receive either an autologous transplant or further conventional chemotherapy, and then getting an autologous transplant if they failed second-line chemotherapy. And in this prospective randomized study, as you can see, there was a clear survival advantage for the use of autologous transplantation compared to chemotherapy, followed by later transplantation, establishing the role of transplantation in this setting. This is a similar study in multiple myeloma. The French were actually the first to do the large randomized study where they took individuals who had multiple myeloma, gave them initial chemotherapy, and then in first response randomized them to receive either an autologous transplant or continued conventional chemotherapy, and again, in a prospective randomized study, showed the strong advantage of autologous transplantation, which still remains the treatment of choice for initial therapy of multiple myeloma. In Hodgkin's disease, much like in non-Hodgkin's lymphoma, patients who had failed first-line chemotherapy were randomized to receive either transplantation following high-dose chemotherapy or conventional salvage chemotherapy. And as you can see, the group that got the high-dose chemotherapy followed by autologous transplantation had improved survival compared to those that got conventional chemotherapy for relapsed Hodgkin's lymphoma. Now, these are a series of hematologic malignancies, and more recently, a very impressive result has been seen using autologous transplantation to treat patients who have a severe autoimmune disease. The idea here is that if you have a patient whose own immune system is reacting against them, and you take out stem cells, and you treat the patient with very high-dose chemotherapy, plus ATG, and then give them back their stem cells, it allows the immune system to reset itself. And you can get responses in very severe autoimmune diseases. Now, most of us felt that you might get a response, but it was unlikely to be that enduring. But that does not, actually is not the case. This is a prospective randomized study that was recently published in the New England Journal, in which patients, in which patients were randomized with severe scleroderma to get either an autologous transplant or conventional immune suppression. And you can see both progression-free and overall survival are markedly improved by getting autologous transplant for severe scleroderma. There are similar studies ongoing now using autologous transplantation to treat other autoimmune diseases, including multiple sclerosis and some rare diseases, including stiff man syndrome, et cetera. So a very large area of potential application of autologous transplantation. Now, in allogeneic transplantation, it's been much harder to do randomized studies. And so what we have done in the past is to rely on the fact that not everyone has a donor. And so we've done a lot of studies in which we do donor versus no donor comparison. So patients, for example, with acute myeloid leukemia in first remission, we took a large number of these individuals who were in Seattle, and those patients who had a matched sibling went on to an allogeneic transplant. And those that did not have a matched sibling were treated with conventional chemotherapy, and you can see a very large difference in this first study showing the role of allogeneic transplant as a treatment for AML. This has been done as well in acute lymphocytic leukemia for patients who have standard risk acute lymphocytic leukemia, showing an advantage for allogeneic transplantation. And it's been harder in some cases to do the randomized studies, and so in diseases like myelodysplasia, we have been forced to do case control studies showing for each case we have comparing an allogeneic transplant with follow-up of a person who does not have a donor, and showing that, again, for patients with intermediate risk myelodysplasia, allogeneic transplantation provides improved survival. In some diseases, the results with allogeneic transplantation are so remarkable that no comparison is necessary. 2/3 of patients with aplastic anemia die within 3 months of the diagnosis if they don't get a transplant. And this is work that came from Rainer Storb from our institution, along with George Georges, showing that we now have about a 95% cure rate with aplastic anemia if you have a matched sibling getting a transplant early on after diagnosis. Really a remarkable impact. And similarly, we have now excellent outcomes in hemoglobinopathies and a number of immune deficiencies. When you put all this together, the growth in transplantation continues. It's estimated in this slide. These are the number of autologous transplants done every year in the United States. These are the number of allogeneic transplants done every year in the United States. So now we have about 30,000 transplants done in the U.S. every year. But if you look worldwide, the growth has been even more remarkable, and particularly in China, the number of transplants is really growing dramatically. And it's estimated that there are about 100,000 transplants performed last year worldwide. 100,000. So one guy, Don Thomas, sitting there during his fellowship, saw that one paper, had the idea, worked on this, and because of the work that Don did, now 100,000 people transplanted every year. Really a remarkable achievement. Now, while that number has continued to go up, the indications have changed dramatically. In fact, if you go back 25 years ago, to where we started this story after Don winning the Nobel Prize, the major indication for autologous transplantation at that time was actually breast cancer. That was the leading reason we did autologous transplants in 1993. Well, randomized studies failed to show a persistent advantage, at least for most patients with breast cancer. Likewise, the leading cause of allogeneic transplants back in 1993 was CML, chronic myeloid leukemia. That was the major reason we did transplants. Along came Gleevec. And so the two leading indications for transplantation in 1993 now are hardly on the map for transplantation. And now the leading indications for transplantation are autologous transplantation, multiple myeloma, by far the leading indication in the United States, and for allogeneic transplantation, AML. Which tells you that for all of us that are interested in transplantation, we're going to have to pay very great attention to continuing to compare transplants to incoming new therapies, and whether those be CAR T-cell therapies for myeloma or targeted therapies for AML. The idea will be to not only just compare the outcomes of transplantation to these other forms of therapy, but what we really hope is how to integrate them together. And so one can easily imagine that the end game for real cures in myeloma will be doing the autologous transplant, getting patients into minimal disease, and then adding the CAR T-cells so that they can have an ongoing, sustained remission with protection from the CAR T-cells. So it's integrating these two forms of therapy that I think is going to be the challenge. But it will be difficult for one reason. In the past, we had the donor versus no donor comparisons we could do for allogeneic transplants. Now that we have, as I'll mention in the next part of my talk, now that we have cord blood cells and haploidentical transplants, everyone has a donor. So we've lost the ability to do donor versus no donor comparisons, which will be a challenge. We're having evolving definitions of risk categories as we understand more about the molecular nature of the diseases, and we're developing these targeted therapies for small subsets of leukemia. And so in the past, we could compare transplantation to non-transplant approaches for AML. That took a lot of patience to do that. Well, now we have to do transplant versus non-transplant just for AML that has FLT3 mutations that's being treated for midostaurin. That becomes almost undoable given the small number of patients that have that exact subset. And so that's going to be a challenge that we're going to have to face going forward. Well, now I'd like to turn to the issue of tolerability. We published a paper a few years ago in the New England Journal in which we did a very simple thing. We took about 1,400 patients transplanted in Seattle from 1993 to 1997 and compared the outcomes with a similar number transplanted a decade later from 2003 to 2007. And what we found is that in that decade, the likelihood of dying as a consequence of the transplant dropped in half. And because of that, survival improved. Now, why did things get better over that decade? And so we went and we examined the comparison of those patients very carefully. But before we did that, as soon as we published our paper, a bunch of other groups went back and looked at their databases and said, wow, we see exactly the same thing. This came from the CIBM-TR. They looked at patients from, again, 1985 to 2005, and what they found was that in every decade, every 5 years actually, we can go back, the non-relapse mortality went down, and because of that, overall survival improved. We weren't the only ones, along with the CIBM-TR. There was a group that, after our publication, that looked in Stockholm and in Eastern Europe, and they all found the same thing that we had seen in Seattle. So this wasn't just Seattle-centric. This was a global improvement in allogeneic transplant outcomes. Why did this happen? Well, we have an excellent database, so we were able to go back and probe our database very carefully. And what we found was, for example, CMV, which was cytomegalovirus infections, they fell in half. The risk fell in half over that period of time. And that was probably, or almost certainly, due to a prospective randomized study out of Seattle showing that prophylaxis with ganciclovir can prevent CMV reactivation. We also found that the incidence of fungal disease went down. The risk dropped, the hazard ratio dropped about in half. And this was due to a prospective randomized study, again performed in Seattle, that showed fluconazole prophylaxis prevented the development of subsequent fungal disease, mostly candidiasis at that time, less effective against Aspergillus. We also saw that high creatinine, renal failure, decreased over that period of time. Now, there were probably a number of reasons for that, but I would attribute it more than anything else to the fact that we had done a group, not just us, but others have done it as well, a randomized study showing that using posaconazole was every bit as effective as using amphotericin. And so we were able to get rid of amphotericin, or at least as much as possible, which was a very, very tough drug to give. We also found that high bilirubins, the so-called people that would develop veno-occlusive disease, dropped. Actually, the hazard ratio dropped dramatically, 0.24, compared to what it had been previously. Again, here was a prospective randomized study using ursidiol that showed that ursidiol prophylaxis is liver sparing, and so patients have much less in the way of very high bilirubins. And so all these things contributed, and the point I want to make here is that I believe that the same thing is going to happen with our adoptive T-cell therapies, that you have this great insight, transplantation, well, that's great, but then so many other little things made transplantation better. Better nutrition, better pain control, better control of viral, fungal, organ toxicities. They all add together, and at the end of the day, you have a much better outcome. So it does truly take a village to make this happen. We saw much less acute graft versus host disease, and here the issues were a little more complicated. There are probably a number of things that contributed to less graft versus host disease. Well, one of them is improved donor selection. This was work that was pioneered by F.E. Petersdorf, where we stopped using old methods for picking donors from the unrelated donor pool, and now we have molecular typing techniques. And with the molecular typing techniques, we're able to more accurately find unrelated donors who perfectly match our patients. There's also various ways of trying to reduce the incidence of graft versus host disease. One of them is using peri-transplant antithymocyte globulin. And this is a study that has been done at a number of institutions around the world. Another way is to take T cells out of the marrow inoculum. This has also been a way that has been originally pioneered by the Sloan Kettering group that decreases the incidence of graft versus host disease. A third way is using post-transplant Cytoxin, something that's been pioneered initially by the group at Johns Hopkins. Again, this looks to be very effective in reducing graft versus host disease. So there are many ways that people have reduced graft versus host disease, and in fact, we have a grant that's just been approved where we are going to prospectively randomly compare these three approaches to GVHD prophylaxis, all of which appear to be effective. We're not sure which of those methods is necessarily the best, and so we'll ask that question formally. We also see less respiratory failure, and here I'm using this as a surrogate for just overall toxicity to the patient, because the patients that develop interstitial pneumonia early on are those that have a lot of tissue damage. And there again are various reasons why we see less of this. We now avoid the highest dose preparative regimens that we used to use, the very high dose TBI regimens, where we found that we can dial those back a little bit and avoid some of the toxicities. We now measure busulfan. We didn't used to do that. We just gave a dose of busulfan. We know that people are hyper metabolizers and hypometabolizers of busulfan, and so now we routinely give a first dose of busulfan. We measure the blood levels based on how the person metabolizes busulfan. We then change the subsequent doses of busulfan. Other people are using IV busulfan, which appears to be a little better behaved in terms of its pharmacokinetics, but even there, it helps if you moderate the dosing. And so we initially showed that busulfan pharmacokinetics could be used to avoid underdosing and therefore have increased relapse rates, or overdosing, in which cases you had more organ toxicities. We've also found that in many patients we can substitute fludarabine for Cytoxan in a fludarabine busulfan preparative regimen, which appears to be somewhat better tolerated than Cytoxan busulfan, at least in people that have pre-existing liver disease. And so that also has reduced our overall regimen-related toxicities. But I want to guard against the idea that this improved survival is due to reduced intensity transplants. When we look back at that overall comparison between 1993 and 2003 and just looked at ablative transplants, we saw the same overall improvement. So it wasn't due to increased use of reduced intensity preparative regimens. And it's important if patients can tolerate ablative regimens that they receive ablative regimens. This was a prospective randomized study led by Bart Scott from our institution, which took patients with AML and myelodysplasia and randomized them to get either a reduced intensity or a full intensity preparative regimen. And this study actually was stopped early by the DSMB because the advantage to the high dose regimen was so marked. And so this is the difference in relapse rates, reduced intensity versus full intensity. So dose intensity really does make a difference, and that translates into improved overall survival and clearly improved relapse-free survival. So if patients can tolerate preparative regimens, it's important that they get ablative regimens. And of course, what would be really good is if we could provide that same dose intensity without causing the toxicities associated with systemic therapy, and so that's why we're using, for example, antibodies that have been radio-labeled with local acting radioisotopes to give our radiation directly to the bone marrow, lymph nodes, sites of leukemia, and avoid the liver, the lungs, and the GI tract. As I mentioned to you, we really did see this remarkable increase from 1993, 1997 to 2003, 2007 in overall survival. So I asked Ted, the biostatistician and first author on the New England paper, to go back and say, well, it's been another decade. What's happened since 2003, 2007? What's the survival for 2013 to 2017? And there it is. So we continue to improve. Now, why? We've already accounted for getting rid of CMV. We already accounted for using current, very recent antifungals. We have better typing, and that's been since 2003, so that's not new. And the truth is, I don't have the answer for you right now, because we are going back with George McDonald, myself, Ted Gooley, and going back and going through our database to find out why do we see this continued improvement in overall survival. But it's there. It appears to be quite real, and hopefully we'll have an answer for you in the very, very near future. Well, what I've talked to you so far was about the indications and about the tolerability and toxicity of the regimen. Now I'd like to talk to you about availability. When I got to Seattle in the 70s, we would only do transplants on people who were under age 40. We felt if you were over than age 40, you couldn't tolerate a transplant, and individuals that had matched siblings, which is only about 1 out of 3 individuals. And so it was really a small subset of patients that were getting transplants. Well, what's happened since then? We've made transplant much, much more available by tackling the issues of age, comorbidities, and donor availability. This was a paper that was pioneered by our group, and this was Rainer Storb, Brenda Sandmeyer, and others, where Rainer had gone back into the laboratory and asked, what is the lowest dose of a preparative regimen that could get you a graft? Thinking that at least then you could get the GVL effect, the graft versus leukemia effect, even if you didn't have the ablative effect. Now, of course, the ablative effect is important, but it's only important if the patient can tolerate it. And so for older individuals and older individuals that have comorbidities, could you just give a very low-dose preparative regimen, get a graft, and have a graft versus leukemia effect that would be effective? And Rainer was able to show with our group that, yes, you could, in fact, do that with the reduced intensity or so-called non-ablative regimens. Now, since that time, Mohammed Sarar has gone out and said, well, reduced intensity isn't appropriate for everyone. What about people that are healthier that could tolerate it? In the past, we just said, well, if you're over 65, you're not going to get an ablative regimen. Or if you're over 60, you're not going to get an ablative regimen. Then some of us got to be over 60. And we said, wait a minute. And so we then went back and figured out that it's not just age, but it's comorbidities that really make the bigger difference. And so Mohammed went back and figured out the comorbidity indices and used that to pick people who would benefit from reduced intensity and other individuals who still would benefit from getting an ablative regimen. And that's how we now do it. So we have a blended comorbidity age index that we use in assigning preparative regimens to patients. And so if patients are even if they're older, over age 65, but have good performance status, still have good performance status, they definitely benefit from getting an ablative versus a non-ablative. But if they have significant comorbidities, then they will do about the same whether they get an ablative or a reduced intensity regimen. The second issue beyond age and comorbidity is finding donors. And we did the first unrelated donor transplant here in Seattle in the late 1970s. And since that time, there have been 27 million people that have volunteered to serve as a donor for someone they don't know. They'll get no payment for doing this. It's just because they want to do something good. 27 million people, and that in and of itself says a lot about, there's a lot of goodness in the world. Now, despite that very large number, the chance that you will find a complete 8 of 8 match depends on the patient's racial background. And so individuals who are Caucasian, there's about a 70% chance that you can find an 8 out of 8 unrelated donor match. If you're Hispanic, it drops to 35%, and if you're Black, it's very low, it's about 18%. Now, a lot of people look at that and say, well, gee, we just need more Blacks or we need more Hispanics in the unrelated donor pool. Actually, that won't solve the problem. It would help a little bit, but not very much. The real reason behind this is more anthropologic, and this is a little simplistic, but it's thought that civilization began on the African continent. And so on the African continent, every HLA type is present. And then, somewhere between 100,000 years ago and 70,000 years ago, populations started to leave the African continent, and it's thought that these were actually just large extended families or tribes, 250 to 300 individuals, people's guess. And they would take with them only a subset of their HLA types. And then a certain population would go across to Eurasia and then to Southeast Asia. And those are the HLA types that make up the Japanese population. And so we now find, if you're Japanese and you go to the Japanese registry, it's actually pretty easy to find a donor. If another group went to the Middle East and part of them became the Ashkenazi Jews, and again, if you're an Ashkenazi Jew, it's fairly easy to find a match because that's just a smaller subset. And like the Japanese, that group has tended, not entirely, but tended to intermarry, so they don't have a great deal of other HLA types. However, if you're an African American, you have the entire panoply of HLA types that were in Africa. And then, of course, if you have an African American who happens to marry a Japanese, and you look at the offspring there when you have interracial, interethnic groups, the HLA types become very rare and extremely hard to match. Now, to give you, this is, I thought, a fascinating fact. I was talking to the guy who is the CEO for Be the Match, and he showed me these data. In the United States, if you look at all the patients who we start a search right now, who are over age 50, we can find an HLA 8 of 8 match for 54% of them. And that's because this group tends to be 50 age older, highly Caucasian, and so that's what we see in the United States. If, on the other hand, we look in the United States, for all the searches we perform on people who are 20 years and younger, we can only find matches for 34% of them. That's how much the ethnic background in the United States has changed over just 20 years. We are a much more diverse population, both because populations have changed coming in and because of more marriages of mixed ethnic groups. And there's a tremendous amount to celebrate about that. But in terms of finding donors, it's a challenge. So what are we going to do about that? Well, there are several things that are being done. The first is, can we find donors who are not 8 of 8 but are 7 of 8 and give outcomes that are just as good? And this is the primary work from Effie Petersdorf from our group. And what she has been able to do is identify what are called permissive mismatches. And so these are individuals where certain HLA types, even though you're mismatched for one antigen, the outcomes are just as good as 8 of 8. And Effie not only showed this for HLA-C and for DP, but she also figured out the biologic reason for that. And that is because of the level of HLA-C or HLA-DP expression. And so now we are able to, for a lot of individuals, find 7 of 8 matches. And if you do that, then you greatly increase the number of individuals that we can find donors for who are Hispanic or Black. Goes way up if you allow for a 7 of 8 match rather than relying on an 8 of 8 match. Another way to go about this is to use cord blood. Now, cord blood is a remarkable source of stem cells, and these stem cells tend to be naive T cells, which were much more easily become tolerant, and so we can do mismatches for up to 2 or 3 antigens using cord blood. And if we can use cord blood, we get outcomes that are similar to matched unrelated donors, as I'll show you in just a second, but that also accounts for making up a big difference. And so particularly for Hispanic and Black, using cord blood is very, very important as a source of stem cells to allow us to find donors for everyone in need. And thirdly, we've been able to do haploidentical transplants. I mentioned the Johns Hopkins pioneering work using post-transplant Cytoxin in the haploidentical setting with outcomes that look quite encouraging. And if we then take all these forms of donors into play, that is 8 of 8, 7 of 8, cord blood, or haplos, we now can find an allogeneic donor for the vast majority of patients in need. And so that really, I think, is a way that we've been able to expand the availability of transplantation. Now, I mentioned that cord blood gives us outcomes that are virtually as good as matched unrelated donors. This is a paper that Philippe Milano from our group recently published in the New England Journal, and it shows our experience using cord blood transplants and with a comparison with HLA matched unrelated donors, the outcomes are just about the same. They're better in our hands than mismatched unrelated donors, but still the same as matched unrelated donors. But one thing that's interesting is it's for different reasons that people fail. Cord blood seems to have a more potent graft versus leukemia effect. And whether that's because of the mismatching that's there or not, we're not exactly sure. But we see relapse rates with cord blood that are much lower than they are with matched unrelated donors. Now, of course, if the survival is the same, it tells you that cord blood is not as safe as unrelated donors. And so we have to work on the safety of cord blood, which we are doing with the use of adding an expanded cord. A prospective randomized study of that has just been completed. Its accrual 2 weeks ago, and we will have the outcome of that. The preliminary data look spectacular, but we won't have the real outcome until sometime later this fall. We should have it ready for submission to ASH. But if you do go into a transplant with minimal residual disease, we find in that setting that cord blood is definitely better than using matched unrelated donors. And so we pick unrelated cord blood in that setting because of its more potent graft versus leukemia effect. Well, finally, speaking of graft versus leukemia effects, you might say, well, why are we talking about marrow transplantation at a meeting where we're supposed to be talking about CAR T cells and TCRs? And the point I want to leave you with is that this is where CAR T cells began. This is what was the initial genesis of TCRs, and so I think there's a lot to learn from the history of marrow transplantation and to understand where its roots came from. And so I mentioned to you previously that transplantation really began with the spleen shielding study that was published in 1949 by Leon Jacobson. But after the spleen shielding was done, it went on to show a little bit later that this really was a cellular basis. That happened in the mid-1950s. Then in 1957, two guys, Barnes and Lutit, did a really interesting study where they took mice and they inoculated them with an inbred form of leukemia. And then they radiated the mice, and they gave them back stem cells that were either from the exact same inbred strain of mice, essentially identical twin stem cells, or they gave them stem cells from a mouse that was not entirely HLA matched. And what they found was that the anti-leukemic effect was much better if you use stem cells not from the syngeneic identical twin mouse. And that was the first demonstration of a graft versus leukemia effect. That was 1957, so we're talking 6 years ago. That observation was not lost on us in the early transplant period. We felt that, knew that it was there, and so we wanted to find out how could we capture it. And so Alex Pfeffer at the Hutch did experiments in mice where he would take a mouse, give it a tumor, remove the tumor, and then take T cells from that mouse that had been exposed to that tumor, take a second mouse, give it a tumor, give it chemotherapy, and add those lymphocytes. And showed that if you adoptively transfer those lymphocytes, you could much better get rid of that tumor. So that was the first adoptive transfer of lymphocytes, trying to mimic the graft versus leukemia effect. And then, in the late 1970s, the idea that there was a graft versus leukemia effect, theoretically, from mice, was demonstrated for sure in humans when we published this paper, which shows if you do a transplant, the chance that the leukemia will come back is much higher if the donor is an identical twin than if the donor is a matched sibling, even if they don't get graft versus host disease. If they do get graft versus host disease, the chance that the leukemia will come back is much, much less. If you take T cells out of the bone marrow inoculum, the incidence of relapse goes right back up to what you see with syngeneic transplants. So this was the most potent data that there was a real graft versus leukemia effect that occurred not just in mice, but it occurred in humans. And we wanted to find out what T cells were causing that effect. Could we isolate those T cells? Could we take them out? Could we grow them? Could we transfer them? And that really is what we're doing with TCRs and with CAR T cells. So, as you heard from Gary, in around 1990, people started looking at people that had transplants who had relapsed, and they took donor T cells and just infused them to the patient and saw so-called DLI, donor lymphocyte infusion, saw a lot of patients with CML go back in remission. Well, that was encouraging, but it also caused a lot of graft versus host disease, and it was only useful sometime, and so we wanted to increase the assurance that we could do that and do it safely. And so we tried to develop ways of getting out the few T cells that were going to react against the tumor and figure out how to expand them in vitro. And that was the pioneering work that Stan and Phil Greenberg did, where they took out T cells and they co-stimulated them with CD3 and CD28 and found they could get rapid expansion, and patented that, and that actually was part of the intellectual property that led to the formation of Juno. By the early 1990s, we wanted a model where we could successfully transplant these T cells. And so we took the situation of patients who had CMV that were going through transplant. And we said, well, CMV is a big problem. We didn't have ganciclovir then. Could we get CMV-specific T cells from the donor, isolate them, and transfer them to the patient after the transplant? And in fact, in this paper that was published in Science, we did exactly that and showed that you could transfer T cells from the donor to the recipient post-transplant and reconstitute immunity against CMV just as if the person was a normal individual. So that was the first time that antigen-specific T cells were ever transferred in humans. That was in the early 90s. Now, we were interested in CMV for sure, but what we were really interested in is showing that you could just transfer antigen-specific T cells as a prodrome to trying to do this specifically for anti-tumor antigens. And so with that background, we faced the challenges then of how could we take this to the next level. We would have to identify appropriate target antigens. What are the antigens that we want to see on the tumor? We have to engineer the T cells so they would have receptors for those antigens, and then we had to assure that the cells would persist and expand after transfer. And as you heard from Gary, all of those things have been accomplished over the last 10 years, and that has culminated in what you're hearing today about successful CAR T cells. And so now we're taking out T cells from the patient, as you can see here. In this case, we like to do central memory T cells. We take them out. Now, they do have their endogenous T cell receptor, but then what we do is we can add either a different T cell in so-called TCRs, as you can see here. And this one, for example, would be against WT1, which is expressed on AML cells. Or we can add an antigen, chimeric antigen receptor, such as CD19 or CD22 or ROR1. And now we have cells that are T cells, central memory, that are armed with the receptor we want. We know that we can give them co-receptors that will allow them to expand and survive post-transplant, and we can use these therapeutically. And you've already heard from Gary, and you will hear later on today about the remarkable success that we have seen with 93% complete response rates in adult relapsed ALL. We have response rates of 82% in adult relapsed refractory non-Hodgkin's lymphoma, 85% CR rates in ibrutinib refractory CLL. And it isn't just these few cases of CD19. If you go to clinicaltrials.gov, there are over 250 registered clinical trials, and this is just of CAR T cells in the United States. And this is over a year old, so this is probably doubled by now for all I know. I mean, it's enormous. It's just such an exciting time. But what I want to leave you with is that this comes from the history of bone marrow transplantation. And bone marrow transplantation has continued to improve over the years, and it continues to improve because we take a multidisciplinary approach. It's not just focused on the transplant itself, it's on the supportive care, it's on finding better donors, it's about preventing infections, and to do that takes a real team effort of the physicians, the nutritionists, the people working in the laboratory, and certainly the nursing staff and supportive care staff, et cetera. And so it's been a terrific journey from the start of transplantation. In the last 25 years have continued that process. I hope I've left you with some insights about how we have improved it over the years. And I want to specifically, special thanks to the mid-level providers, the nurses, the pharmacists, the dietitians, the schedulers, the social workers, and the other members of the care team, and of course to our patients and their families. Thank you.
Thank you, Fred. You did a very nice job of giving us that historic overview without aging at all in this process.
Yeah, right.
So I would like to invite anybody here. We have a question to ask questions. Thanks, Fred.
Sure.
Your talk was fantastic. Thank
Oh,
you.
thank you.
I actually have two questions. One is there a difference in the stage of graft versus host disease and the impact on GVL? And my second question is there a case for collection of minority cord blood as a default?
So let me answer the second question first. Yes, I think that people are particularly, so both, I would say that both the National Marrow Donor Program for just signing up individuals is still quite active, but we're not all that interested in, I should say, I'm not doing it, but they are not quite so interested in Western European donors. There's a fair number of them. And remember, it costs a lot of money to type someone. And so particularly if it's being done on philanthropic funds for the National Marrow Donor, they want to make the best use they possibly can of the limited typing funds they have. And so they're particularly interested in getting individuals of minority race or ethnicity as normal donors. And similarly, cord blood banks are interested in storing cords from minorities for that particular reason. It's very expensive to store cords, and so there's a lot of interest in using haploidentical transplants, which is much more economical. Whether the outcomes will be as good as cords, we don't know. And in fact, there is now a national ongoing study comparing haploidentical transplants to cord blood transplants, and that'll be very telling. My own personal take on it, and not everyone would agree with me for sure, but I think we need both. I think there's going to be advantages for haploidentical in terms of economics, but I think that the potent graft versus leukemia effect that we see with cords is something that we just cannot afford to walk away on. It's way too important. There are people that are cured that would not be cured without it. So that's the basic issue for your second question. Your first question has to do with, is there a stage relationship between GVHD and the graft versus leukemia effect? And that's a very complicated question. I would say that if you were to look at conventional GVHD prophylaxis measures that were used in the past, yes, you would see less relapse with severe graft versus host disease, but the consequences of severe graft versus host disease clearly overwhelmed any survival benefit of that. If you just take the aggregate of survival plus decreased relapse, probably the best combination, just in terms of survival, was to have almost no acute graft versus host disease, to have mild chronic graft versus host disease. And that's what seemed to give you the best overall survival. But chronic graft versus host disease, if it's mild, is tolerable. If it's significant, it is very difficult, and it really decreases your quality of life. In fact, Stephanie Lee from our institution recently showed that patients that develop significant chronic graft versus host disease are 50% less likely to go back to work than people that don't develop chronic graft versus host disease. And that tells you that's real significant. So our job, and what our dream is that we will develop a transplant approach where we can find a donor for everyone, we can get a graft, we can get patients into complete remission, we can get them free of graft versus host disease, and then we can add back targeted specific T cells in the post-transplant period to ever prevent the relapse. That's our dream transplant. And that's why I think that the combination of transplantation and these new immunotherapies are we have to improve both of them, but while we're improving both of them, we have to pay attention to how we hopefully will ultimately integrate them together to get the best outcomes for our patients. Other questions?
Hi, thanks, Fred. I was wondering if you might comment on the early days of sort of developing the transplant program, and what are those things that were really important when you're working in a land where it feels like sometimes there's more questions than answers, and we're still waiting on data and things to prove some of the things that we need to do? What were the things that were really helpful in that time of ambiguity?
Well, it's a great question. I'm not sure that I have a simple answer for you. I have to say that the early days of transplantation, I suspect, are something hopefully like the early days now of CAR T-cells, that the thing that drove you the most was to see someone come back a year later that without that therapy would not be there to come back. To see people whose lives have actually been saved. And that was such a powerful thing that it helped override much of the other difficulties. But it's not for everyone. I mean, when Don first started doing transplants, among the first 100 patients that we transplanted, we had 12 long-term survivors. Now, that's something to celebrate. You have 12 people that are alive that wouldn't have been alive, but you had to face giving bad news to 88 other people, telling them that their disease had recurred, or that they had graft versus host disease that we had no therapies for. And that was, it takes a special kind of group to do that, where you have you're in it together because it's such a noble thing to try and accomplish. Don was, he was very, he was a very committed guy. He commanded a lot of respect because of his intellect. He was both, he had this interesting combination of characteristics. On the one hand, he was kind of like the Godfather. You'd be in rounds and someone would tell a joke and nobody would laugh unless Don started to laugh. And then everyone would laugh. And then Don would stop laughing and everyone would stop. But at the same time, he was incredibly generous with his praise. And so if, whenever anything was accomplished, he would say, that Reiner published this or Fred published that, or, and he was so generous with his praise of the nurses and how important they were. He recognized early on in the transplant the many different problems that the transplant patients had, and would seek out individuals who had special talents in those areas. And so he would have individuals, for example, one of the big problems we had early on was the kids were just starving to death because we had no way to give them nutrition. So he said, well, what can we do about this? And then they said, well, maybe we could try using an arterial venous shunt like they use in dialysis. And so he got an individual who was a pediatric nephrologist to come over, and that was Bob Hickman. And so Bob looked at the problem and said, oh, I have another solution, and he invented the Hickman catheter. And so suddenly we could provide nutrition for the patients. We had individuals who, back then, we had a lot of problems getting platelets. It was very early days, and so he hired a woman, Murad Benaji, who was just there to find platelet donors and do the typing to figure out platelet compatibility to solve that problem. Infectious disease were huge, and so we had infectious disease people who weren't just the man or woman who happened to be on infectious disease service that month and would come over, but we had people who came over and just focused on the problem of infectious disease in our transplant patients. And so Joel Myers came early on. He's the one that figured out how to give prophylactic ganciclovir. So I think we were putting people into laminar flow rooms back in the early days. When they were in laminar flow rooms, we had to figure out a way to sterilize the food. And so we had a dietitian her whole interest was in providing sterilized food. And so she would take food and radiate it. And then after radiating it, which gets rid of bacteria, and actually that is how you can radiate food and sterilize it. But then she would make us, the young faculty, taste it. And I'll tell you, radiated cheese is really bad. It oxidizes but fruit, you can't tell the difference. So, but we had dietitians who were just there. So the answer, I would say, is to recognize all of the problems that you face. Of course, the basic one is the scientific problems of T-cell therapy, but then it's all the support staff, it's all the complications that occur, and to seek out specialists in each of those, and to share that data very, very, very carefully, and do what you can to form that nucleus of people, and not just have if it's a new therapy, not have it mixed up with everything else and homogenized. I think that it takes focus, it takes a lot of attention to all the subtle differences, and so you're going to need people who are specialists in the disease that you're treating, specialists in CAR T-cells, specialists in supportive care issues, specialists in the economics of how do you get the person there and how do you get them back and forth, and how can you make it accessible in long range. I know that we have had how do you do contracts with the pharmaceutical companies for this? I mean, it does take, and I know it's hackneyed to say it, but it really does take a village to make it happen, that it be focused on that vision of making this a curative therapy going forward.
Thank you for your amazing talk. Me and my coworkers work on the bone marrow transplant unit at UW, and it's really cool to see the history of all the drugs that we give and why we give it.
Great.
My specific question is regarding cord blood, and I was wondering if you could speak to the kind of pre-screening that we do. I imagine when someone's matched in the donor, database for allo transplants, that there's a lot of pre-screening once you've been matched to be sure you're still eligible to be a healthy donor. But for the first time, I have a patient who's here for her second double cord transplant.
I know who you're talking about.
Donor-derived relapse. So I'm like, how does that happen? What kind of screening are we doing to these cords that sit with such naive cells? Like, how do we find that they're eligible other than just cell count? And I'm just curious if you could speak to any of that.
Say hi to AW for me, please.
I will.
So it's an interesting problem. What we do with the cord bloods is that we take a history from the mother about her health and about any possible familial health problems that they might have. The cord blood is screened for common infectious issues, but that's the extent of what we do. So we don't do mutational analysis to look for is there possible that the kid had an in utero leukemia and you're going to transfer that leukemia to the patient. And we don't do that for two reasons. Number one, the likelihood is so vanishingly rare that it just economically does not make sense. But the second issue is that, and so here's the story, this patient had a cord blood transplant initially, was doing fine, and then 2 years later developed a different kind of leukemia, and when we looked at that leukemia, it actually was in the cord blood cell. It wasn't in her old leukemia recurring. Now, in the few cases where this has happened, we've gone back and asked, oh my God, what happened to that infant that gave the cord? And well, in every case that it's been looked at, the infant's been fine. So this isn't something that likely was from the infant that gave the cord. It probably is something that after the cord was transplanted, leukemia developed in that cord cell. Now, it does appear that this happens more frequently after cord blood transplants than it does after unrelated donor transplants or after matched sibling transplants. And why that would be is a mystery, and something that people are very interested in looking at. It's also possible that there's some microenvironmental factor that increases that. It's conceivable there's some exposure to toxicity, but it does appear that this is something that did not happen in the infant, that if we had screened, we wouldn't have found it. It wasn't there. No. No. Sure. Questions?
Hi, I just wanted to ask, I think one of the profound things that's different now as opposed to when auto and allo transplant came about is this media attention that CAR T and immunotherapy has received. So we have patients, I come from University of Pittsburgh Medical Center, coming to us and saying we want CAR T. And I think one of the early things we're struggling with is for these relapsed refractory lymphoma patients who don't have any other options, how do you struggle with patient selection that's appropriate versus not offering it to patients, if that makes sense? Like, how do you not show them they know you have your ace, but you're not going to play it, even though they have no other options?
Well, I'm not sure I have an answer for you. Of course, when patients are referred to Seattle, the first thing that we do, and we have an intake office, the first thing we do is to try and understand what ultimately is in the patient's best interests. What gives them the best chance for long-term survivor? And we try to make sure that they get to that place. As far as accessibility to therapies like CAR T-cells, well, most of those are not commercially available, and so we have clinical trials that they are eligible for, and if patients are eligible for clinical trials, they get on them in a first-come, first-served basis, as long as the eligibility criteria are met. We don't ration them as long as they are, it's FDA-approved studies, and so the clinical trials are very, very rigid in terms of their criteria, but if it's a first-come, first-served basis that they go on. It's not as if we don't have a lot of very difficult ethical discussions, whether it's with CAR Ts or with transplants. Should you do a third transplant? Should you do a second transplant in someone that has a short remission? So, we try to do the best thing we can, and I would say that for example, our transplant group, we have a meeting every Wednesday at 10 o'clock. It's attended by most of the transplant attendings. It's a room that generally has 50 people in it, and we present all the difficult cases, and people discuss them openly and hopefully fairly. But I am sure that there are many, many more patients who could qualify and benefit than we have the capacity to do. But our job is to get the clinical trials run so we can prove the efficacy, so that we can get the industry out there to produce these. Now, it's a very expensive procedure right now. But I'll just tell you one fact, that I was early on the advisory board for the first company that produced a monoclonal. It was early on in the days. It was IDEC, and they were thinking about producing what turns out to be rituximab. And we're sitting there way, way before it was anything to speak of, and we said, it costs $1 million right now to produce a gram of antibody, because you had to inoculate each separate mouse, and then you had to go and you had to get the ascites out of that mouse. And people were saying, could this ever be a therapy at $1 million a gram? It was just impossible. Well, right now, 6 of the 10 top-selling drugs in the United States are antibody-based. 6 of the top 10, not just for cancer, but for anything. So I really do believe that if it works, people will figure out a little black box where you'll be able to put in someone's blood and turn out a spigot a week later, and the CAR Ts are going to come out. Really, I mean, it's going to happen. Our job is to prove what can be done. Industry will figure out a way to make sure that it does get done. We have to pay attention to that, of course, but I firmly believe that. Okay. Okay, well, thank you very much.